This podcast is brought to you by eRadio. For more podcasts, check out our website on eradiosa.com or download the eRadio SA app from the Google Play Store. Enjoy.
Time once again for Medical Monday right here on eRadio, and as always joined by ophthalmologist Dr. Dylan Joseph. And last week we were outside the eye with laser vision correction. Today we're going inside the eye and talking about the true definition of cataract surgery. Dr. Joseph, hello, how are you?
How's it, Jan? Very good, very well, thank you. We've just completed a great cataract list this morning and a laser list this afternoon. So, a Wednesday where I can get to involve myself with my passion is a good Wednesday. So, looking forward to showing you and discussing the alternatives to laser vision correction.
Yes, of course. And then today, the true definition of cataract surgery. Let's just quickly start way at the beginning for those who missed it. What exactly is a cataract?
The lens inside the eye is very similar to a lens inside a spectacle. But this lens in the eye has the ability to change shape. And this lens lies just behind the colored part of our eye called the iris. And in the middle of the iris, you've got the pupil. And the pupil is where the light rays travel through. So as they've gone through the pupil, they go through the lens. And the lens has this amazing ability to change its shape to allow the light rays to fall perfectly on the back of the eye, depending on the distance that we're looking at. So whether it's reading a cell phone, reading a computer or desktop, or looking into the distance, this lens, while we're young, has that ability to either become very thin or pretty round to allow us to read. So as we start hitting our 40s, mid-40s, early 50s, we start undergoing a process called dysfunctional lens syndrome. So where this lens actually itself starts stiffening up, becomes a little bit harder, where the muscles become a little stiffer. Remember I talked about being able to do only 100 repetitions of a biceps curl at the gym before your muscles start to take strain. Not just dissimilar to that is the way the muscles around the lens function. So that lens has a set lifespan, or the muscles around it have a set lifespan before they start saying, hey, listen, I can't pick up these weights anymore. And essentially our arms become too short. And that's when the lens starts dysfunctioning. It's not per se cataract, but it's the very early stages of the lens starting to change. So we'll discuss a little later the options of replacing this human lens when it's dysfunctional, because we don't have to necessarily wait until it becomes a cataract before we replace it. But once we hit our 50s and 60s, once we get to what we call grade 3 dysfunctional lens syndrome, this lens starts taking on a different hue, a different color. So from all the ultraviolet exposure that we go through, and if you're a smoker as well, it often hardens the lens a lot more prematurely. So that lens becomes yellow-brown earlier, and it's like putting a filter in front of your camera, a brown filter in front of your lens. You're going to filter out a lot of the good light, and your image quality that you take, or your picture that you're going to take, is going to be substandard. The quality of the image is not going to be great. Now, very interestingly, the brain has an amazing ability to compensate for that decrease in vision quality, or compensate for the contrast loss or the loss of color, especially if it happens at a very similar rate in both eyes. So if your vision quality is degrading over time and it's happening at a similar rate in your left and your right eye, the brain has the ability to just say, okay, well, this must be normal. Let's carry on as normal. And then you keep on wearing your spectacles until you get to a point where now you're cleaning your specs more and more, you're turning up the bedside light to see a little bit better, and people say, hey, hang on, my night vision is not great anymore. I'm starting to see glare and halos around oncoming lights, which I never experienced. And this is when you start developing what is called a cataract. And that's clinically significant. So as a refractive surgeon, and I tell all my patients two things. Well, I get them to answer two questions when they are ready for cataract surgery. One, do you want to improve your vision quality? And is this going to improve your quality of life? And secondly, do you want to reduce your dependency on spectacles or contact lenses if you wear them? So that makes the journey or the questioning process a lot more simple for the patient to answer, rather than waiting for a cataract to mature to the point where we've got serious visual loss. A patient can now make those choices themselves. Do they want to improve their vision? Do they want to reduce their dependence on specs and contacts?
So now, Dr. Joseph, people come to you and let's say, for example, they've got a cataract. What exactly... Okay, now you're going to perform surgery. What exactly is it? How does it work?
So the surgery is done nowadays under conscious sedation, which means you have a drip up. You're nice and drowsy. We put lots of numbing drops onto your eye. I think people's fear around cataract surgery is that it's going to be sore, one, that it's going to be uncomfortable, and two, that how on earth are they going to keep their eyes open? It's the same that we said about laser vision correction last week. Those things you do not need to worry about at all. We look after you from a pain perspective, and we keep your eye open. So conscious sedation really keeps you on a bit of a level, a trip, so to speak, so that you don't feel pain. And it also, the medication that our anaesthetists use have the ability to take away your short-term memory. So people don't associate the experience as negative. And then they often say that they're looking forward to their second eye being done. So it's all done under topical anesthesia drops. So no injections around the eye, no needles around the eye. Over 55, 60, we tend to stay away from general anesthesia anyway, because the associated risks are a little higher, especially if you have what we call comorbidity, so high blood pressure, diabetes, high cholesterol, heart problems. So we'd far prefer to keep you awake. And at the end of the day, people sail through the surgery and the recovery is exceptionally quick. So, the next day we see you in the clinic, we give you a schedule of drops to use for 3 to 4 weeks, and you're up and away and back to your normal routine.
Yeah, that's amazing, eh? Now, next question is, what is customized lens exchange?
Let's go back a little bit to the dysfunctional lens syndrome age, which is generally in your 40s and early 50s. But prior to that, in your 30s and 20s, the lens is essentially clear and it's functioning very well. Okay? Medical aids will fund a procedure when there is cataract development or clouding of that lens. Prior to that, they don't fund that, and that then becomes the patient's responsibility or the patient's account. So when we're looking at customized lens exchange, we're essentially removing a normal human lens, but substituting it for a technology that will allow you to be free in most circumstances, if not all, of spectacles and or contact lenses. So when a person is perhaps not a candidate for a laser vision correction procedure, or they're not a candidate for an implantable contact lens procedure, we then can look towards options which are replacing the human lens. And in certain conditions, it's actually better to consider human lens replacement surgery rather than laser vision correction or implantable lenses. For example, people that have got very short, crowded eyes, they run risks in the future that the pressure might suddenly rise in the eye. Now, when we look at the diameter of the thickness of a lens from front to back, it's about 4 millimeters on average. And when we remove this, we replace it with a 1 millimeter thick lens, which essentially decompresses that space. So it reduces a number of risks in patients that have perhaps narrow eyes or short eyes, and that could end up with high pressure rises. So there's a number of indications for removing that human lens. And when we remove it, we can look at certain technologies in the lenses then to say, okay, well, are we going to target distance? Are we going to target computer, near, a combination of the above? That's a discussion that we'll get into just now. But a customized lens exchange procedure is where we remove the human lens when there is no cataract present. That these are alternatives to laser vision correction to still give you the same, if not a very similar result.
Next question, what lens technologies have you got available when considering these surgeries?
That depends very much on a patient's lifestyle and what they want out of their vision. Generally, there's a few categories of lens technologies available. The first would be lenses that correct your distance vision. as best we can. And I say to my patients, you've got about an 85 to 90% chance that then you may not need spectacles for your distance, but you will need spectacles automatically after the surgery for anything from your desktop computer range inwards. So we call that near vision spectacles, not readers, near vision spectacles. So anything from desktop through to reading, the patient will then need. Okay? Some patients who perhaps are artists or painters and their entire world and life exists at a 50 to 60 centimeter range say, listen to me, I don't want to wear specs for that range, and I don't mind putting on spectacles for going outside. We can target you with the same lens technology to just have that set distance. But there are very few people that operate at 90% of their day at that distance. So we often have a really candid discussion as to the different visual ranges that are important to them, and we end up targeting often something called blended vision. Now, blended vision is where we take the dominant eye, the brain's dominant eye, and allow it to see distance and desktop range, and then the non-dominant eye to see desktop range and computer. And there are really great technologies now available which work on what's called the zoom corridor or extended depth of focus, EDOF or EDOF lenses, which can improve the functional range of vision, essentially getting you to a point where you're spectacle independent broadly. It is very important, however, that one discusses the phases that the brain needs to go through to adapt to this lens technology. And lastly, we have a technology called trifocal technology, and some lenses combine now trifocal with extended depth of field technology. Now, most people panic and say, hang on, if it's a trifocal, does that mean that there's a progressive zone in the lens? Do I have to look up and down like I use my multifocal spectacles to look at the computer or look at a book or look in the distance? No, it doesn't work like that. These lenses have very specific set focal lengths. So you're in focus at 40 centimeters, you're in focus at 60 centimeters at the desktop, and you're in focus at distance. Once again, there are compromises to these forms of technology, and it's vital to sit down and have the discussion with your patient about what technologies have what compromises and where is the patient prepared to compromise in their lifestyle, what's going to work out best for their chosen tasks and their occupation. And so, we often have like a flow diagram where we sit and work out with the patient. That's why history is so important, taking into account what they do. And that's where we talked about or touched on that Vivior lifestyle monitor a few episodes ago, where if a patient is uncertain, we can actually fit this artificial intelligence monitor to their spectacles. They go home for 4 or 5 days and they collect visual data for us to actually show us how much time are they spending reading, how much time are they spending at the computer, and how much time are they spending distance. We graph it for them. We can then show them. It gives them an objective and subjective reading of their data that they're needing on a day-to-day basis. And it makes their decision to choose a specific lens for their lifestyle a lot easier. And they're therefore prepared to maybe compromise on certain aspects of those technologies because they know that it's going to improve their functionality so much more.
Dr. Joseph, let's talk about the adaptation phases involved. How do you train your patients?
So the adaptation phases are really critical when you're using blended vision technology. Remember, blended vision is one eye set for distance and desktop, and the other eye set for desktop and reading. And classically on day one, people have what's called the wow factor. Wow, I can read, I can see distance, I'm happy. The second phase that they go through is something called rivalry. Now, where the brain says, hang on, I'm now picking up that my one eye is doing better on the near work and the other eye is doing better on the distance. That rivalry phase can last up to 3 months or so. During that rivalry phase, we have brain training exercises, and we've got that on our YouTube channel, Ian. So we've got our brain training exercises on our YouTube channel, and we've got our neuroadaptation talk. It's about a 5-minute talk that I go through and offer patients to go and sit down and read through again and again and again, or watch again and again to help them. So that neuroadaptation or brain training during the rivalry phase is important. Once they get towards the end of the rivalry phase, they start entering what's called suppression. So suppression or indifference is basically where the brain says, okay, you know what? I don't actually need my left eye for distance as much as I need my right eye. So it starts switching off that image, so to speak, and vice versa. And then after that, which may take another 3 months or so, they enter the blended phase. And the blended phase is where the brain really doesn't know which eye is doing which. And depending on whether they're reading, seeing the computer, and looking up, their brain automatically rewires itself to use the eye for that specific task. It's like the analogy I use for my patients is learning how to drive. So learning to go from first to second gear, clutch and accelerator. It's a process, and you're rewiring neurons. But the beauty of the brain is that you're rewiring that. It has the ability to rewire itself, but it can take some time and patience. Very few patients at the end of that period come back and say, listen, I can't get used to the blended vision. But the beauty is now we have options to reverse that for them. So even though we're making a permanent change to the inside of the eye, as a refractive surgeon, it's always important to have some form of treatment option available if it doesn't work for the patients, which is very rare. The adaptation or neuroadaptation for trifocal lenses is slightly different. We always warn our patients that you're going to need really good light to use these lenses for your reading. And the one thing is night vision is a little bit different because these lenses have rings on them, or the majority of them do, which split the light. So people will notice halos and glare around oncoming traffic, around street lamps, around the moon and stars. But we show them an animated video on our software here in the office that indicates that as the brain adapts to it, so these halos get a little bit softer and they get smaller, but they don't ever disappear. So it's really vital as a clinician to say, well, these are the pros and cons of this technology. These are the pros and cons of this second technology. Which one is going to suit your lifestyle better? And which of the potential compromises are you going to be able to adapt to better? And from that perspective, that's what makes the refractive surgeon's job a little bit tricky than just putting in a standard lens for distance. But it gives us such happy patients at the end of the day, knowing that they are in charge of their own vision. They are far more free of perhaps specs and contact lenses than they were. And those compromises get less and less and less as the patients adapt to the lenses.
So, Dr. Joseph, we can go and see these videos, the brain training exercises videos also on your YouTube channel. Do we just search for your name?
Yes, yeah. They search for my name on the YouTube channels, Dr. Dylan Joseph, and they will see that there's a whole bunch of videos. We'll have our podcasts up there as well, so people can listen to them. I talk through short-sightedness, far-sightedness, if people are interested in that. And very often, the majority of my patients do get premium lens technologies in the form of, multifocals or extended depth of fields, or even torics, which we haven't discussed yet or touched on yet. So I'll discuss that just now. But those brain training exercises are often great to go through in week 1, and people come back to them again at week 4. And it's there permanently. We actually also send them directly to the patient's email address after they've had their surgery. So they get it on the email address and they get it on YouTube.
Now, Dr. Joseph, we've talked about astigmatism previously, astigmatism correction with laser. Can we correct astigmatism when doing cataract surgery and customized lens exchange?
Absolutely, Jan. This is actually also considered a form of premium lens correction. So our premium lenses are the extended depth of field, they're the trifocal lenses, a combination of the above, and or toric lenses. Toric lens corrects astigmatism. So astigmatism, remember, is rugby ball shape of the eye. And what's vital as a refractive surgeon, we look at a number of machines to give us detail as to the magnitude of astigmatism, or how much the cornea looks like a rugby ball, as well as the axis. It's really important to have those values critically close to each other so that we can work out the best toric lens or astigmatism correcting lens that's going to go into your eye. So that toric lens or astigmatism correcting lens can come on its own. It can be incorporated into an extended depth of field lens. It can be incorporated into a trifocal lens. So remember, astigmatism, if we do not correct that, you have 100% chance that your distance vision, your near vision, is going to be blurred after surgery. Mm-hmm. So when people are looking for spectacle or contact lens independence and they've got significant astigmatism, it's our job to say, well, how much astigmatism do you have? And are we going to use a toric lens to correct this astigmatism? The higher the magnitude of the astigmatism, the more likely it is that we've got to correct it. But from my perspective, I correct even the smallest amounts of astigmatism because it is visually disabling. So that it's not a question of putting in two different lenses, a toric lens and another lens. That astigmatism is built into the lens of your choice. That's the beauty of it, and that's why it's also called a premium lens, because it is a customized lens that is going to correct the shape of your eye to give you the best quality vision when we do cataract surgery. So to answer your question, absolutely, astigmatism can be corrected and should be corrected to give you the best quality vision that you can get.
Doc, just give us a summary quickly of what we discussed today and all the lenses available when we are considering cataract surgery or customized lens exchange.
I think it becomes very, very daunting and confusing for a patient when they are faced with making these choices. These are lifestyle choices, these are life-changing choices, and that's what we're here to do, is to try and offer a patient as much information about the lens that is best going to suit their vision. Now, it obviously has got to do with a very critical exam from front to back of your eye. Your tear film has got to be in good order, the back of the eye, the gel in the eye, the corneal shape has got to be great. So a patient has to be a good candidate, especially if they're considering premium lens technology. But in summary, it depends entirely on what the patient's visual needs are. A patient can come to me for either of those surgeries and say, Doc, I want to go back into specs or contact lenses afterwards. Great. We simply correct the distance that they are looking to be broadly spectacle independent for, be it distance or near. Or they say, listen, I'd like to look at broader range of spectacle independence. And we say, okay, let's look at your lifestyle. How much time are you spending at what different distances? We look at your visual optics, your cornea, the health of your eye, the tear film. Do you have dry eyes? And we then say, well, this technology is going to be best suited for you to try and bring you the broadest range of spectacle independence, be it in the extended depth of field lenses or the trifocal lenses. And then lastly, the astigmatism correction can be done either on its own or in conjunction with one of those technologies to give you the best quality vision. So we look at your eye, we look at your important details around your lifestyle and what is going to make you the happiest. And we strive for that. I mean, 90, 80%, 85% of our patients are bang on target after surgery. But as a refractive surgeon, we offer you the ability to fine-tune your vision a minimum of 6 weeks after surgery if you're not quite satisfied with the distance or the near that you've got. And that's the beauty of being able to have our laser vision correction platform with us. So that's it, Ian. I think if you are struggling with vision, if you feel that you are not seeing as well as you would like to anymore, or even if you're looking for broader independence from contacts and specs and you think that you're over the laser vision correction age, which we will be able to tell you if you are or not, then there's options. 96% of people, we can find you an option.
That's so fantastic. Thank you once again, ladies and gentlemen. That was Dr. Dylan Joseph. That's where you're supposed to insert an applause here somewhere now. Dr. Joseph, how do we get in touch with you?
Ian, our website is www.drdylanjoseph.com. You can contact our offices directly and speak to Mariska on 044-150-0085, or her email address is info@drdylanjoseph.com. You can also find us on Instagram and Facebook, and as mentioned earlier, on YouTube, where we have a whole bunch of educational videos for you.
Oh, that's nice. I'm definitely going to go and check out your YouTube channel. Looking forward to that. Doctor, thank you so much once again for a very interesting Medical Monday. Looking forward to next week.
Absolute pleasure, Jan. Have a great one.
This podcast was brought to you by eRadio. For more podcasts, check out our website on eradiosa.com or through the eRadio SA app from the Google Play Store.